team from this side and the physician here and the primary care and all of that together to get the best care for the patient. Oops, I'm sorry. Often, currently, navigation, if it isn't well coordinated, the burden of that falls on the patient or the patient's family. And that can work okay when the patient is a very good advocate for themselves. But obviously, inequities here are pretty significant when the patient cannot advocate for themselves. So the idea of navigation tools, whatever they may be, and in some places this is just having a navigator, for example, that is the tool to do these things. But having a tool it's really been used in pancreatic malignancies and other HPV tumors to really facilitate coordination. And you can see from that pie graph on the right that the blue is clinic, like this is supposed to represent the amount of time spent in different parts of a job for a navigator, and the yellow is coordination. So it's a very significant part of what our patients need. And navigation tools in their aggregate really have been shown to reduce psychosocial burden for our patients, improve our efficiencies, and be cost effective. So our study really, we aimed to evaluate if a navigation tool management at our own institution. And primarily, this was a feasibility trial to show that we could enroll patients, that the technology would work, that it would be able to answer our questions so it could be studied in the phase 2. So this is just a screenshot of the way one of us would look at our dashboard of patients. This is not what the patient sees, but this shows you a number of patients. And then the various, as you go across the columns, you can see different variables. So we have, for example, blood pressure and heart rate and weight. And those bars are the patient's steps each day, or the distance that they walked. And so we can kind of monitor in this sort of way, quantitative assessment of how the patient's doing. So this was a single institution recruitment over 2 months. And we enrolled like 3 to 4 patients per week, all having a large HPV operation, so a mix of pancreas and liver. And there were some benign patients in this because some of them was unclear if it was malignant or benign, and we just really wanted to test the tool more than it's necessarily just its application in cancer. We measured patient engagement, and we could, through the app, basically see how many things they looked at, how long they looked at it, how often they looked at it, and over what duration. And then subjectively, we had an anthropologist on the team who basically did qualitative interviews of all the care team members and the patients to figure out which aspects served them best and which things were redundant, which things, really were most meaningful to the care team. And you can see there we had 20, I can't really see that far, I'm sorry, 26 patients. I think 4 were withdrew or were not able. We had a little bit of issue depending on your operating system, if you could use the app. And in the end, the virtual interviews were done with nearly all patients, and the same with the providers. So I just want to give you a flavor of the preoperative types of educational materials. We basically took what we were currently doing and digitized, not just taking the form and digitizing, but making it into digital content. So instead of just having like a page that says what to bring to the hospital, we basically turned it into, a list of pictures of different types of things. So kind of consumable bites. And we push these out to patients at various intervals based on how long before surgery it was. So there were basically tips for families and friends that how they could help the patients. There was, instructions about what to do when you arrive to the hospital, where to go, and pictures of the entrance and pictures of the pre-op area, that sort of thing. What you need to bring, what you shouldn't bring, and then just some coping strategies as well for patients. And this turned out to be really something that the patient would request frequently, like how can I get through the day before surgery, or what tips do you have for that? Okay, and then post-operative tasks, we would send them in advance, the red flags of, when to call, what the common problems to look out for. We obviously did a lot of medication tabulations here to make sure we knew how much they were taking and of what. And probably most helpful to the surgeon group is that the drain output was monitored and recorded daily. Pictures were uploaded up the drain. So it was very easy when a patient called with something to quickly look and see what was going on and make a triage decision where the patient needed to be seen or if they needed to come in. And then obviously some usual things about how to deal with side effects of medications and other things after surgery. The daily task, each patient was asked for the drain to, if they had a drain, and not all of them did, but the ones who did to record their drain output daily into the app, to record their weight, how much they walked. Our current version is actually wearable, so that is being counted by the device itself. But in this version, the patients were writing down how far they walked. There were regular surveys of fatigue, and this was really the postoperative recovery scale that we used as well. And mood, importantly, we watched as well, and then the uploading of either a wound or drain of photos. Here's an example of what we would basically see as the output for drain data. This is a patient who had 2 drains and called with decreasing output. And, basically this is, this would be coupled with the photos as well, in a kind of a separate screen. In the interviews, what we noticed is really that a lot of patients, and this was fascinating to hear the anthropologist describe, but basically what the patients felt by having information just inherently less anxious, no matter what the information was. They felt that they could get to it. They knew the answer. They didn't have to wonder if there was something they weren't thinking of. And they really felt like the content that was there, if they wanted to know more, they could trust that this was what we wanted them to know and wasn't just a Google search of somebody else sort of like that. They had easy access to the care team through the app. There wasn't two-way messaging, but they basically felt that they could report to us and show us exactly what was happening. In the second version, and one of the important feedback points was that patients wanted a way to make sure we had seen what they entered, and that functionality was not in the first version, and certainly obviously was overlooked because patients were wondering, as I'm entering this, is anyone looking at this? Because I feel like I'm in free space. So that really helped. And then it really allowed easy postoperative communication amongst the care team, because anybody could log on to this in the OR or whatever and check if there was a patient phone call or something like that. And then we were able to detect, this is a small number, but there were 2 clinical events, one a patient with very high blood pressure and another patient with a drain that clearly became problematic at home and what was brought to the hospital based on the drain appearance alone. So in conclusion, this app really enhanced our perioperative education by providing patients with really complex care, a trusted resource for education in both pre and postoperative settings. It improved communication and it prompted the patients to basically participate more in their care and track their own information, which I think kind of activated the patients to help themselves. And also, really, we felt that the results from this, our easy ability to enroll, the patient's acceptability of the interface, as well as the care team, that we were planning to push forward to phase 2, as I described. Thanks, that's all I have. I'm happy to take questions if we do that.
We have a couple of minutes, so if anybody wants to ask a question, Amy.
Yeah, this is the bane of all apps, but essentially Cerner, we use Cerner, and we needed the phase 2 money to push the integration forward. So that is happening, but it is clunky right now. Even in the phase 2, it will go in a note, not in the vitals or not in the I's and O's. So but that's the ultimate goal of all apps, is that you wouldn't need to look at a separate dashboard. And the integration is, I think, forthcoming, but it's a painful, long, expensive process. Yeah.
Emily, quick question. So obviously patient satisfaction and patient safety of utmost concern, but how about advanced practice satisfaction?
Yeah.
Was this a burden for them, or did they enjoy it? Did it make life easier or harder?
Yeah, that's a great question. I mean, in part, the way we did this, it was clunky for the provider. Like, I had to manually go in and sign every consent. I had to log on, myself. But and at the time, actually, Jackie was well, I won't go into it, but she left us for 2 years for her husband back there, and came to New York, which anyway, so while she was there, she was working for the company doing some of the interviews and stuff like that. So we had an APP that was doing the routine work. And I would say in general, if it were fully functional, it was a huge help to them, but it was the burden of enrollment and logging into a separate site that really changed things. But basically not to have to call people, as frequently, and to know if you called somebody, it was for something important, right? And the patients were always texting pictures to people's phones and that sort of thing. And it just made that streamlined. And also I think they felt that they could easily, like that dashboard, they could see all the patients at once and know who was out there with a drain and, and make sure that everybody was getting in. So, yeah.
Last question. So do you think this app actually saved a life because you could see the drain output change color or output a couple of days before?
Well, saved someone's life. I wish. I mean, the patient lived, I should say, but it was bloody drain output and the patient came for an angio, but was okay. But I mean, there is that potential, right? And I think in the end, this is just close monitoring. And it's probably meant more for anxiety and satisfaction and workflow than it is actual ultimately patient safety.
And I heard version 1 and version 2. What's in version 3?
Yeah, it depends. The main thing is the integration with the EHR. And once that's done, if we can easily generate a work list in Cerner and keep tracks of the patient that way. And then the other part that's in too is integration with across specialties. So medical oncology, rad onc, and GI. Is the point is to integrate all the steps that the patients go through.
Thank you. Great effort. Thank you. Next speakers are Amy Lorenzo and Liza Hillel from UPenn.
Good afternoon. Thanks to the AHPBA APP team for including us today. So our clinical question is, how good are the current pancreatic cyst guidelines? We're going to present a case and attempt to answer that question. My name is Liza Hillel, and I work in the Division of Gastroenterology at the University of Pennsylvania.
And my name is Amy Lorenzo, and I am a nurse practitioner in the Department of GI Surgery at the University of Pennsylvania. So our objectives for today are to talk about the nature of IPMNs, intraductal papillary mucinous neoplasms. We're going to review a live patient case and compare and contrast the current pancreatic cyst guidelines. We're going to incorporate our case into those current guidelines. And then we're going to talk about some lessons we've learned and future pathways.
So we all know that an IPMN is a precursor lesion for a pancreatic adenocarcinoma. And prevalence data shows that up to 14% of patients over the age of 40 can have an IPMN. Other data shows that it can be as high as 40% in those over the age of 70. The revised Fukuoka guidelines show the annual progression of a branch duct IPMN to high-grade dysplasia can be anywhere between 1.4 and 6.9%. So given the visibility of an IPMN on cross-sectional imaging, it's logical to survey them. So the first set of guidelines were developed in 2006, and by 2018, there were 5 sets of guidelines.
So the patient that we're going to focus on today is an 81-year-old male. He has multiple chronic comorbidities, and he has a first-degree relative of pancreas cancer in his father. He was incidentally found to have a pancreas cyst in 2011, and for this reason, an MRI was ordered. The MRI revealed a 1.3 by 0.5 centimeter bilobe cystic lesion in the head of the pancreas, and an EUS confirmed the diagnosis at this time. As you can see on this image, where the red arrow is pointing, there's an innocuous-looking small cyst in the head of the pancreas with no mural nodule, and an otherwise healthy appearing pancreas with a normal pancreatic duct. Patient had fairly consistent surveillance with intermittent MRIs and CAT scans for several years. And at 8 years after the initial image, there were stable IPMNs, but the main pancreatic duct was top normal at 3 millimeters. An MRI 1 year after that showed stable cysts and main pancreatic duct. 10 years after the initial MRI, the MRI showed stable IPMNs, but new main pancreatic duct dilation to 7 millimeters. An EUS was repeated at that point, and the the cyst showed to be stable at that time, but the main pancreatic duct was dilated at 8 millimeters. There were no other concerning features, and at that point, an MRI was recommended in 1 year. As you can see on this side-by-side image, the original MRI shows a nice, normal, thin main pancreatic duct, and the image on the right shows the 7 millimeter dilated main pancreatic duct.
We're going to break away from the case and talk about the development and timeline of the pancreatic cyst guidelines. So the first guidelines were published by the Sende group in 2006. They were revised multiple times. And by 2018, there were 5 sets of guidelines from GI surgery and medicine organizations from Japan, Europe, the AGA and the ACG in the United States. And the American College of Radiology first published their guidelines in 2010, and they were revised again in 2017. So all the guidelines agree that IPMNs with high-risk stigmata, including cysts larger than 3 to 4 centimeters, those with main pancreatic duct dilation, and with solid components, all warrant EUS, FNA, and surgical consultation. As we know, surgery is the only definitive care for an early pancreatic cancer. The list at the bottom displays a more nuanced group of worrisome features per the ACG. Now on this slide, we're going to talk about how the guidelines diverge. So some guidelines recommend repeat imaging in 6 months after initial cyst discovery. Some recommend repeating in 1 year, others 2 years. The AGA recommends cessation of surveillance after 5 years if the cyst hasn't grown in size. And the American College of Radiology recommends cessation after 10 years if the cyst remains stable. Other guidelines recommend lifelong surveillance as long as the patient remains surgically fit. So this busy graphic compares the 5 sets of guidelines. Now we're going to return to the case.
So to recap, 10 years from the original MRI, the patient's imaging showed stable cysts, but interval dilation of the main pancreatic duct to 7 to 8 millimeters per MRI and EUS. There were no mass lesions or any other concerning features, and FNA was not done at that time on the EUS. So 2 months after that most recent surveillance imaging, the patient presented to the ED with acute right upper quadrant abdominal pain. The labs revealed elevated transaminases and an ultrasound concerning for acute cholecystitis. The ultrasound also showed a dilated main pancreatic duct, more so than the MRI that had been done just 2 months prior. So an MRI with and without contrast was ordered and revealed a dilated main pancreatic duct, as seen here on this image, where you can see the red arrow pointing to this very dilated main pancreatic duct throughout the whole gland. But it also showed a 3.5 by 1.9 centimeter hypoenhancing pancreatic head mass with biliary and pancreatic ductal dilation, highly suspicious for pancreatic adenocarcinoma. What? How could this happen? This patient has been imaged for 10 years with CAT scans, MRIs, endoscopic ultrasounds. How is it that we didn't see this lesion? There was no evidence of any solid lesions or any concerns indicating that there might be some pancreatic cancer forming. This isolated case struck our pancreatic cyst team, and it highlights how the pancreatic cyst guidelines can be ineffective in detecting early cancer.
So let's incorporate our case into the Fukuoka and AGA guidelines. So we remember when the cyst was first found incidentally, it was 1.3 by 0.5 centimeters. And so per the AGA guidelines, we would repeat imaging in 1 year. And as long as it was stable, repeat imaging every 2 years for a total of 5 years. So 5 years later, the pancreatic cyst measures 1.0 by 1.1 centimeters. So really, all in all, it grew a mere 3 millimeters. So potentially we may have, stopped surveillance. Now, per the Fukuoka guidelines, we'd repeat imaging 6 months, every 2 years, for 1 year after initial cyst discovery, then annually for 2 years, and then every 2 years for the rest of the patient's life, as long as they remain surgically fit, and as long as the cyst hasn't developed any high-risk features. So 10 years later, the cyst is now 1.7 by 1.4 centimeters. not considered a high-risk size. However, the main pancreatic duct is 7 millimeters on MRI and 8 millimeters on EUS. So according to the AGA, that main pancreatic duct dilation is considered a high-risk feature, warranting EUS, FNA, and even surgical consultation. For the Fukuoka guidelines, actually, the main pancreatic duct is to be greater than 10 millimeters to be considered a high-risk feature. So really, based on the two above guidelines, the patient potentially would have been lost to follow-up. So what lessons have we learned and what are the future pathways? So clearly there's multiple guidelines, all with varying recommendations. And really they're based on expert opinion and not scientific evidence. And in this case, even with guideline divergence and close surveillance, the cancer was not detected. So many of you may be familiar with the clinical trial, the EA 2185 that's taking place around the world and evaluating patients with, or kind of comparing low intensity versus high intensity surveillance. So maybe with the results of this trial, we will better be able to manage this IPMN pandemic.
We want to highlight that this is an isolated case. Most of the time, the guidelines are effective in picking up high-risk cysts. And although this case is unsettling, we are happy to report that the patient is status post-Whipple resection. The pathology revealed a stage 3 pancreatic ductal adenocarcinoma without any distant metastasis. The margins were clear and he underwent adjuvant therapy with FOLFIRINOX and FOLFOX. The most recent imaging showed no recurrent disease, and we're happy to report that. Pancreatics are a pandemic, and the management of these mostly benign acting cysts can seem futile at times. Although we have learned a lot over the years in terms of surveillance and when to be more aggressive with further evaluation and surgical consultation. So the answer to our proposed question, how effective are the pancreas cyst guidelines? Well, they're pretty good, but certainly not perfect. Thank you for your time. Happy to take any questions or comments.
A wonderful talk, both Amy and Liza. I'll open up the mic for anybody to ask a question.
So I think one of the unique things about this case was that the patient did have not a clinical family history, but had a first-degree relative with pancreas cancer. So I'm curious if they underwent genetic testing, the patient themselves, because by definition now they have clinical familial pancreatic cancer.
It's a good question.
Yeah, we'd have to ask our surgical colleague who is very familiar with the case left yesterday. But I'm trying to think if we tried to, I don't think the patient has.
I don't think they had, I don't believe they had
But it would
genetic
make
testing up
sense.
front. Right.
Oh, clearly they
Agreed.
should.
Yeah.
Right. Especially if they have children.
Mhm.
Any other questions?
All right, Lindsay and I probably were jotting down the same thing.
Yeah.
So really nice overview. I think you raised, some important issues with these patients who initially the patient didn't meet criteria for high risk screening. But I think with that family history, you have to really think carefully when you see these subtle changes on imaging. I always wish we had that crystal ball to take these patients to the operating room the day before they develop cancer.
Sure.
But they're certainly a challenging population to kind of weigh the risk and benefit for surgery. And are you guys following tumor markers? Were there any changes in the C19-9 in this individual or?
I think their tumor markers were
Always normal.
they were always normal. And so unfortunately, but it wasn't like a routine thing. I think sporadically when there was a mild change, they had drawn the tumor markers, and we should have mentioned that. I apologize.
But that's not something that we normally do in our practice. Something that you do. So you order tumor markers like a CA19-9 on every patient with a pancreas.
Every year with their routine imaging. Interesting.
We don't do that. Do other people do
Yeah.
that in the audience?
So tumor markers. I think the one thing that, Ken, the surgeon, wanted to point out when it kind of all erupted was, our routine protocol every year for patients with cysts like this is an MRI without contrast. Is that seem to be the standard with? So So our radiology department had developed this pancreas cyst protocol, and it has been MRI without contrast. So the concern was when this all erupted, if we had done an MRI with and without, would we have seen this earlier? Hard to say.
We'll take one more question.
I'm just curious if y'all tested cyst fluid, like whenever y'all
That's a
did
great
the
question. The
EUS.
cyst was never FNA'd per the gastroenterologist. And yeah, so.
Now, the where the tumor developed was not the cyst itself. It was kind of more proximal to that. So not sure that even if they did FNA it, if it would have shown anything, but it was not done. So
Amy, thank you. Liza, thank you. We are running short on time, so
thank you.
wonderful talk, and thank you for the discussion. Our next speaker is Tiffany Zavadsky from Northwell, New York. She's our keynote speaker, the development of APP-led HPV program and other role expansion opportunities.
So I want to thank the HPBA for inviting me to speak at this session. If I could put a plug in for next year to make this earlier in the program, that would be great. I'm very anxious to get this done and over with. My name is Tiffany Zavadsky. I'm a nurse practitioner in surgical oncology at Northwell Health and the Cancer Institute. I've cared for HPV patients for the last 14 years, both as a nurse and as a nurse practitioner. And worked in both the inpatient and the outpatient settings. So in addition to my outpatient clinical role, I also focus on process improvement and standardization of oncology care across the system and across the different phases in care. So the purpose of this presentation today is to present potential opportunities for advanced care providers or ACPs to expand their role across the continuum of the cancer care continuum. Northwell has implemented some of these programs we're going to talk about. While a few of them are in their infancy, we've seen some positive results in quality of care, efficiency, and patient outcomes. And so our HPV patients deserve high quality, standardized care in a personalized and people first environment. And as I'm sure all of you are feeling this as well, but the current landscape in healthcare is ripe with roadblocks in preventing the timely delivery of life-saving and quality of life improving treatments. So the number of cancer survivors is expected to increase to over 26 million in 2040, which is about a 68% increase from 2016. So as the demand for oncology visits increases, the supply of oncologists is only expected to rise about 14% during the same time frame. So we feel clinician shortages in oncology and primary care and in the subspecialties needed for ongoing cancer issues. Further, the AANP reports that only about 1.2% of nurse practitioners and about 2.5% of physician assistants are working in oncology care. So on top of this increasing demand, the health needs for our patients are also equally complex, and we kind of lack this team approach and underutilized subspecialty services and also underutilized ACPs, in my opinion. Despite the ACA, we continue to see patient access issues and coordination difficulties, and we lack comprehensive cancer care and survivorship programs nationally. So every health system has its own intricacies, right? No matter the location, the workforce, their size. So there's no standard solution to fixing these complex problems. And we also all live in the real world, right? So it's financially and resource constrained environment. So it's imperative that we create efficiencies to ensure minimal, if any, impact on the quality of care for our patients. In 2019, I moved from a healthcare system that had about 6 hospitals, 4 surgery centers, and about 40 patient care locations to Northwell Health, which is the largest health system in the state of New York. And it encompasses 23 hospitals, 11 ambulatory surgery centers, and about 700 outpatient facilities. So this larger footprint and diverse patient population are complicating and compounding factors that already stress the system and challenge its services and providers. So what can we as ACPs do to kind of help with this issue, and where can we have the most impact? So an essential part of our role and the traditional utilization of ACPs in oncology is typically during the active cancer phase of treatment. And that makes logical sense, right? Independently seeing our own patients not only offloads the physician schedules, but and captures revenue for our services, but it ensures we continue to improve on our own clinical practice and competency. It makes us more accountable to our patients, and it leads to more autonomy, which in my opinion, leads to better job satisfaction. But our role as APPs are still really untapped, I think. And we have opportunities to expand our reach to address the system-based gaps in care, specifically in multi-D team building, prevention and cancer screening programs, patient access and coordination. We also need to be thinking about the future care delivery models and ensure we're training the next generation of skilled ACPs in specifically in clinical oncology. So the following discussion is going to highlight some of these efforts we've begun implementing at Northwell and we've seen some really positive results within our organization and for our patients. And then we'll also touch on the future of incorporating artificial intelligence now that we've laid the initial systems groundwork. So the multi-D approach to care clearly demonstrates improved quality and patient outcomes. It's been well studied. I don't think we're going to hear any arguments otherwise now at this point. But adapting this kind of approach in a geographically large and culturally diverse patient population really needed to be carefully considered. So in 2019, we developed the first multidisciplinary cancer clinic at Northwell, and we started with pancreatic cancer. So this is an ACP-led program that set the stage to provide personalized, high-quality care to every patient throughout our region, no matter where they live or how they entered our vast network. So patients now undergo uniform data collection and imaging, and their cases are reviewed at a virtual centralized tumor board. And then the patients are then evaluated by their local providers in their closest regional PMDC site. And then the subsequent treatment recommendations and the therapies are delivered at one of our 700 outpatient facilities that's convenient, that it's a convenient location for the patient. So this type of model addresses the access issues that we were having. It controls for the variability in care. It ensures that all patients are able to be assessed for clinical trials, which is really important to our system, especially with our diverse patient population and the underrepresentation of minorities in clinical trials. And it addresses the transportation concerns and social determinants of health. It's basically high quality, standardized care delivered right in the patient's backyard. So how are we doing? One of my resident colleagues, who I think is presenting also somewhere else at this meeting, she studied this model and presented these results at SSO last year. So 90% of the patients that came through our centralized PMDC sought care within our system as compared to 40% in the non-PMDC patients. The mean time from referral to PMDC appointment is now 4 days as compared to 15 days prior to this implementation. And we found that our PMDC patients were more likely to undergo neoadjuvant therapy as well as curative intent resection, although the latter did not reach significance. So this model of a centralized tumor board review with a regional PMDC and a local treatment delivery system really worked well for our geographically large system. On patient feedback, 95% of patients said they would refer one of their family members or loved ones to our PMDC clinic. Although I don't actually love these standard survey questions when it comes to cancer. I really hope they don't have to refer their family members and loved ones to our center, but nonetheless, they had a positive experience, given the circumstances. So we're continuing to grow our PMDC volumes, and last year we hired an HPV-specific clinical trial nurse, which clearly improved the screening and enrollment in HPV trials. So while the impact of multi-D teams, I think, is most striking in the outpatient setting across the care disciplines, I would be remiss not to mention the importance of continuity of care across phases, particularly in the inpatient surgical setting. There are some of my former colleagues and coworkers here in the audience that I definitely took for granted because at Northwell, the inpatient ACP surgery model is like that of the residents. So they have 4 to 6 week rotations through the various different surgical services and the ICU. But our HPV patients, they really demand highly focused expert care in every setting. So in October of 2022, just this past October, we opened a position for steady state inpatient advanced practice. So she, not only in addition to her kind of clinical role in the hospital, but she also helps maintain our pancreas and liver multidisciplinary, enhanced recovery pathways and discharge notes and order sets that have also been ACP derived. So that's another good opportunity. She collaborates with the nursing education, with the nursing staff, with the residents, and most importantly, ensures that our HPV patients have the appropriate education and resources that they need prior to discharge so that they can have appropriate self-management at home. This type of role is also really well suited to identify future quality improvement initiatives that will help continue to push our standards higher. So we just had a great pancreas cysts. So when we're talking about cancer screening and prevention programs in pancreas cancer, that's exactly what we mean, pancreatic cysts in high-risk individuals. And these types of programs, though, they really need to be ACP driven. In my opinion, there's really no better marriage of skill and need when it comes to this. So about 10%, and I saw a couple of other different percentage points previously, but I'll go with the middle there, 10% of the general population have pancreas cysts, often incidentally found. So many patients don't receive the appropriate follow-up recommendations. Some are kind of dismissed as benign and they don't follow up at all. Some patients are never referred to a pancreas specialist to direct management. And worse, some patients present years later with a full-blown pancreatic cancer that could have likely been cured previously with a resection. We're also encountering patients that have known genetic mutations and meet clinical guidelines for pancreas cancer screening that are never referred to a geneticist or to a pancreas specialist for evaluation. So these are 3 patient examples specifically that I've seen just over the last year. And as Amy and Liza mentioned in their presentation just earlier, I would actually make the argument that it's not kind of one-offs. I think we see much more of this now. So the first patient here is a 74-year-old who had an incidentally found pancreas cyst in 2009. He was undergoing surveillance with his GI until 2019 with stability of this cyst. So his GI said, it's been 10 years, you've had stability of the cyst. I don't think you need any further follow-up. Well, unfortunately, he presented to our PMDC in October of 2022, so a couple of years later, with a locally advanced pancreas cancer, who's actually currently on neoadjuvant therapy right now. The next example is a 69-year-old who also came through our PMDC in September of last year. He unfortunately had metastatic adeno with carcinomatosis. And in his pre-PMDC interview, he was found, when the nurse practitioner asked about his family history, noted a father and a brother with pancreas cancer. So even despite this, he was never referred for screening or for genetic testing. And then the third example it's a little bit of a different one, but kind of Amy and Liza touched on this as well. This was a patient, a 73-year-old who had a Whipple in California back in March of 2021. His sister lives in New York. He relocated to our state and actually just presented to establish care and for his own cancer surveillance. So when we saw him in the office, he also has a family history of a father with pancreas cancer diagnosed at age 45. But despite that, and despite his own cancer diagnosis, he did not undergo genetic testing and was not offered that at the time of his diagnosis. And so we recommended that he see a geneticist, and also has implications exactly to what your guys' point was earlier for his offspring. So they now meet the clinical guidelines for pancreas cancer screening. So we recommended that his children also receive screening. So these are just 3 cases. You guys have brought up several other cases. I'm sure you've seen this all in your clinical practice as well, where subpar management can really lead to detrimental outcomes. So in 2020, we developed a pancreas cyst and high-risk surveillance clinic at Northwell. This is another ACP-led initiative and program built on evidence-based practice guidelines tailored to the individual patient. This is another opportunity where ACPs can independently see and bill for these patients and help offload the lower complexity surveillance patients off of the surgeons and the GI schedule. So our program saw a 3.5-fold increase in volume from 2020 to 2022, where we saw 169 patients last year. I do think the most significant finding here is that physicians outside of our system have now started to refer into our program as well. So I anticipate that the volume will continue to grow over the next several years. So the next opportunity I want to discuss is in patient navigation. And Dr. Winslow, if she's still in here, even as a third string, did a great job with this presentation as well, and the importance of navigation programs. I think that there's still a lot of room we can do for improvement in navigation. So as we mentioned before, the current cancer care delivery system in the US is siloed, it's fragmented, it's inefficient, and it really does leave it up to patients to kind of figure it out on their own. And in general, in my experience with other different institutions in different states and different systems, the navigation programs tend to be discipline specific, meaning that patients maybe have a navigator that's paired with them while they're getting chemotherapy or while they're on screening or while they're in surveillance. But we do a really poor job, in my opinion, of we fail to cover the entire treatment trajectory. And I think the reasons are multifactorial here, but the point I want to make is that fixing this entire system, it's not only incredibly difficult, it's really expensive to do so. And I don't think it was any different at Northwell. I think we were finding really difficult times trying to take care of our patients as it pertains to navigation. So last year we piloted a breast navigation program to take a lot of this burden off of our patients. So we now pair newly diagnosed breast cancer patients with a nurse navigator at the time of histologic confirmation all the way through to survivorship. And it's been incredibly successful. As you can imagine, if you are a patient and you are going through all of these different phases, but you have one point of contact. If you have a question or concern, you are calling one person and that person is going to figure it out for you on the back end. It's no more of this, I'm calling the surgeon and they're like, well, no, this is a medical oncology issue. And then you're calling the radiation oncologist. No, this is a radiation oncology issue. And I'm seeing a lot of head shakings here because that means that I'm kind of on point. It's terrible for our patients, right? So we've seen super success with the breast cancer navigation program so that we are able to expand and dedicate resources into other disease sites. So we recently initiated a single point entry navigation structure called Cancer Care Direct. And this is for right now Northwell employees, families, and friends newly diagnosed with cancer. They can call, email, fill out an online form, and we get them plugged in immediately with a navigator with expertise in their cancer diagnosis that will follow them through their continuum and on to survivorship. We're launching this in a phased approach. So the first rollout was January 9th of this year, and we plan to complete this rollout in April. So as of February 13th, we were able to direct 72 patients to appropriate navigation teams. So that's just about a month. And that's only in our employees, families, and friends. Right now, we're really focused on optimizing the clinical and operational workflows with our employees as we complete the framework for our navigation program and offer these services to the general public later this year. So while much of the day-to-day operations are performed by nurses, I think it's really essential to have ACP involvement in the navigation platform build. We understand the high-level clinical decision-making in the diagnosis and treatment of cancer. We also understand how things get done, right? Like we understand where the hangups are in the system, where the gaps are going to be. We appreciate the patient needs at the point of care, and we really are the connection between these two levels. So we really have to be at the table in order to build a cohesive and efficient navigation program. So I feel very strongly, clearly, that ACPs play an integral role in the development and implementation of comprehensive cancer programs. But what are these programs, the multi-Ds, the screenings, the navigation programs, like all have in common? Or I guess even a better question is, how does a patient get to you in one of your clinics? Well, it comes through a referral. And in my opinion, I think this is really where the crux of the issue is. So we were finding that in our system, identifying patients with pancreatic cancer are often unrecognized until they are referred to a specialist or to an oncologist. But a referral is a passive strategy, right? And it really relies on the skill, the resources, and the commitment of the patient and or their current care provider to make that appropriate next step for future care. And the problem with passive strategies in medicine is they don't work, right? So despite all the growth in the programs that I've just mentioned, we're continuing to observe that we have several patients that are diagnosed with pancreas cancer within our system that are not reviewed at our tumor boards, that are not getting care here. And they're really multifactorial issues, but the point I want to make is we can really only take care of the patients that we know about, right? We can only take care of patients that were referred. So the future of healthcare is going to be leveraging artificial intelligence to take the burden of manual data entry and the physician referral process off practitioners and put it in the hands of AI systems. So we have several opportunities to provide proactive, optimal care much earlier in the diagnostic timeline, such as at positive family history, like we were talking about, positive screening test, a suspicious radiographic evaluation, or at the time of histologic confirmation. So over the last year, Dan King, who is one of our very intelligent, forward-thinking medical oncologists, piloted a computational natural language processing model to review these types of textual data sources to find patients or to recognize patients when there was a finding suspicious for or diagnostic for pancreas cancer. This has been incredibly successful in accurately capturing these patients. And this idea for him was born out of the low clinical trial enrollment. So now what do we do with these patients though, once we find them? And how do we provide the best care for them? So now that we have our infrastructure in place, I think the next step is going to be using AI to identify and connect the right patient with the right ACP-led program at the right time when they need it to deliver the right care. So for my nurse practitioners in the room, this is very reminiscent of your RN training days of the 5 rights for medication administration. I never thought I would pair the two of those together, but they seem to work really well. So that's what I'm going to go with. And speaking of training, that's the last aspect I want to touch on is the future of our profession and the need to prepare the next generation of skilled oncology ACPs. So Northwell actually has an already robust ACP fellowship program, which is obviously ACP led and driven. And they have existing tracks in CT surgery, emergency medicine, ortho, hospital medicine, primary care, neurology, and neurointerventional radiology. But last year we expanded and built the first oncology specific ACP fellowship track. And we graduated our first fellow in October of 2022, and she seamlessly transitioned into one of our smaller community hospitals, and she's providing treatment for inpatient and outpatient oncology patients. So the ACP Oncology Fellowship encompasses the full spectrum of care, including consultation, development and implementation of treatment plans, follow-up, and survivorship. It includes cross-discipline education and training, in several different disease sites and exposes both inpatient and outpatient setting training. So the fellows training is focused on the multi-D care model, which in my opinion is absolutely necessary to become an outstanding provider in the dynamic field of oncology. The fellowship program prepared an ACP for a bright future in oncology, but the one piece of this that I wasn't actually anticipating when we built it, but was a pleasant surprise, was that it actually created a bi-directional information flow. So if you remember, the first multi-D cancer clinic at Northwell was developed in 2019. So now we have an ACP fellow whose focus is on multi-D care. Now she was exposing already existing practicing ACPs in various clinical settings in our hospitals to the importance of the multi-D collaboration and the importance of multi-D care. So this is instilling a culture shift at our institution that is advancing existing ACP practice, which ultimately is going to raise the bar and benefits all of our oncology patients. So in closing, clearly ACPs can help bridge the capability gap in clinical practice, but we should also be intimately involved with the program development as we understand the high-level clinical decision-making, how things get done at the point of care. We need to leverage technology to become more efficient and transform the way we deliver care. And we're responsible for training the next generation of talented oncology ACPs. Thanks. I can take any questions.
Definitely a great talk. I'll open up this mic for anybody from the audience to ask her a question.
I don't want to put my my surgeon on the spot right now, but he kind of focuses more on that. I kind of provide the clinical direction. It's a very good question. Yes, so we had the existing ACP fellowship. It was already existing at Northwell, and as you can imagine, it does make sense, right? Because we're using part of the fellowship though to actually onboard the fellow, right? So we are saving money up from that perspective, from the financial standpoint. Stays, yep, exactly. That's a very good question. And that means I think it's our job to make sure that we're competitive and that we are making it very difficult for them to leave our institution, right? That's on us to ensure that we keep them. That's retention, right? Anybody else?
So Tiffany, one question is, what do you think the role of APP is in like quality control? Like every few weeks, the residence rotation changes, every few years, and attending changes. But I find like the APPs are the cornerstone of a good quality program.
I agree with you, which is why we hired on a steady state ACP, because we weren't having that. We didn't have that initially. So as you can imagine, rotating ACPs throughout every 4 to 6 week rotations. It's kind of the jack of all trades and master of none approach, right? So I think it's incredibly important that you have steady state ACPs to help with the resident education. You know, at my previous institution, that is like the cornerstone of their treatment. So they are enhancing the residents' education. They're enhancing the nurses' education. They're kind of that go-to person as an expert in the care. So yes, from a quality perspective, absolutely necessary to have them involved.
Impressive as always. My question is regarding these platforms that you're building. Obviously, there are a lot of resources, time, and effort that goes into it.
Mhm.
So once these are fine-tuned and developed, what's the future plan for commercialization or getting other institutions access to it? I'm not asking you this.
My IP lawyers would not allow me to answer that question. But no, all joking aside, yes, you know, that's something that our lawyers are looking at right now in terms of getting this up off the ground as something that potentially we could be offering to different facilities. Mhm. Thank you.
Tiffany, thank you so much. Great job. For our next session, I'll ask the panelists to come up. And our speakers are all obviously invited to be a panelist. So our panelists are Sarah Reed from Duke, Lindsay Manners from Johns Hopkins, Anna Landon from Duke again, and Megan Bulauka from NSK. So on the app, you can ask us some questions. So I'm going to open up the app and for the next 30 minutes, we'll go down the topic. So the first question is again, pancreatic cyst. So if you did not have like a multi-D session, like Tiffany has at her program, if you get a phone call about a trauma patient with a cyst, maybe he's already discharged. And so what do you do? Like, it's a lot of work looking through the chart, finding the patient, calling the family member, finding a physician who's going to follow him. What do you think?
So I have some colleagues that can help keep me honest. I've been at Duke, I guess 11 years tomorrow, but I was outpatient for 6 and inpatient for 5. And then last week went back outpatient. But they've improved a lot since my outpatient days. And one program that I think is really great is the ECOM program. So, someone may come in the ER and have an incidentaloma. The ER can place a referral to ECOM. And so then this referral goes into a pool managed by APPs. We'll see this patient needs a workup. We'll do a cursory review, can order studies, and then set up that patient for a new patient evaluation in the right discipline. So it keeps people out of the ER, can expedite their care. And so you have, an experienced APP just looking at this pool of patients and coordinating some studies. So I think that that's a good way to get patients in the right place quickly. And then we also have a PA who works as a PA navigator. And so she has been tremendously helpful, used to work as a colorectal PA. And so she will screen the new patients that come in. She'll reach out to us and say, hey, so-and-so's coming in, their scan. I don't know if these are all the phases that you need. And so she has clinical background. We'll reach out to us. And so then we can coordinate care when they come in. I think prep is priceless to make sure when patients come into clinic, they have the studies that they need. So you can give them appropriate recommendations instead of, then sending them out for additional studies. So I think that highlights where APPs can really help to streamline that on the front end, keeping people out of ERs and avoiding admissions just for expedited workup and then getting them into the right clinic.
So are these a lot of phone calls or like billable events like televisits?
So the referrals can be placed by a provider. And then when the APP pulls that patient from the referral, that is not a billable action because then that consult wouldn't be billed. But then that APP who sees that patient either telehealth or in person will bill for that visit.
So we'll go to the next one. On the outpatient side, what are the best cases or patients that can be to differentiate between an MD or an APP independent clinic?
So I think, the best sort of may vary based on a few things. Firstly, a level of expertise of the APP that will be practicing in that manner, the communication or relationship that is established between the surgeons and the APP, and then also the goals of the program. So the short answer is any type of patient, I think, is appropriate and can be transitioned to independent APP clinics. If this is a role that is new or you're just getting started, I think it makes a lot of sense to start with the post-op patients or those that require surveillance, either in a pancreatic cyst format, surveillance, survivorship, something like that. And that can be structured in many ways. You can alternate visits with the physician or the surgeon, depending on how frequently they're seen at any interval that is desired by the program. At this point in my practice, I see both of those types of patients, and I also will see new patients just as a means to improve access to care and get our new patients in the door quickly. So I think there's a lot of just comfort between of the APP, the practice, and then also, again, the goals of the program, as I mentioned. And then the communication piece, I think, again, can function in many different ways, but I always encourage APPs who are going to start practicing in this way to have a conversation with whatever surgeons or physicians that you're going to be working with, because it's important to know how everybody desires their optimal communication to be. Is that emails, phone calls, in-person meetings, what's going to work best for you? I was very fortunate to work with a surgeon for many years who we had an established rhythm that we would meet just for 5 or 10 minutes twice a week. Sometimes that happened, sometimes it didn't, but we had these sort of points in the schedule that we were able to potentially talk with each other. And then also he knew when I was calling, he should really try to answer. And he prioritized that. Well,
Thank you. Anybody else?
yeah, so for the most part, I have my own templates. Patients are scheduled in with me. Of course, there's always the scenario where it's sort of not immediately unpredictable, but the week before the schedule changes, you have to add an OR case. And so the clinic gets shifted over to my schedule. In that case, we really do try to have one of the administrative staff contact the patients and say, Dr. So-and-so is not available. We can move you over to Lindsay's clinic. I found that offering them a choice from sort of a behavioral economic standpoint is really valuable. So you can see Lindsay on Tuesday at the same time as scheduled, or Dr. So-and-so can see you in 2 weeks at X time. And so for the most part, you've given them that choice, they can decide. And then there's also sort of the scenario where it's that morning and, things go awry. And so you show up instead of the surgeon. And yes, there is, always a little bit of disappointment, I think, in that scenario, but, that's sort of when you have to, just sort of be confident in your skill set and make sure you listen to them. And usually by the end of the visit, patients are fine. And then if it happens again in the future and they know who you are and they have that experience, they're okay.
So we do exactly the same. But I have found in my experience, specifically with New Yorkers, I'm still new to the system, but they are hell bent on seeing like their surgeon. They have always ever seen their surgeon. So I found it very beneficial for my surgeon will actually initiate that conversation at the time of that appointment. So you're going to see me now, and then next year you're going to see Tiffany for surveillance, and then you're going to see me back for surveillance. And when it comes from the surgeon, the patients are much more likely to want to see you. And I talk with all of my patients much more often and for much more time than my surgeon does. So we've built a rapport, and usually I have never had an issue where the patient didn't want to see me for ongoing surveillance. But I think the point is, if it's initiated by the surgeon, you're going to be much more likely to have success in that area.
Yeah, I do agree, because I think a lot of times too, they'll the patients when they'll mic chart you or message or call, they're usually speaking to us. And so we kind of build the rapport, and they, know our names. And so usually they're a lot more understanding when, we come in and talk to them as well about it.
So we'll go to the next question. So does it matter, like doing consults on the floor or even maybe outpatient, whether it's a resident or an APP from medicine or surgery? Does it change the outlook of the patient or the family in regards to surgery or palliative care? Does it matter? Should it?
Okay. I feel like a lot of our patients oftentimes will be referred to our surgeon's office first. So we're sort of the point of entry. And they'll come in, for example, with obstructive jaundice, they need an ERCP or a stent placed. So they get admitted through our urgent care. And because they kind of saw our surgeon first, they end up coming onto our service. We'll usually get them drained. And then depending on whether or not their tumor is resectable, get them off to medical oncology or get them ready for, prep them for surgery. And I think a lot of the questions, if they're locally unresectable, when they enter into our system, most of the time, it's because we're gonna get you off chemotherapy is usually the conversation. So when they're kind of just first coming in, we usually aren't having palliative conversations with them.
To echo a little bit of what Megan said, I think surgery plays an important role for these patients who present jaundiced, because there may be a patient who is jaundiced from a resectable pancreatic cancer that we actually don't want to stent before surgery. And so, to avoid that low risk of ERCP-induced pancreatitis, if their bilirubin was, 4 and they were going to go to the upfront surgery. And I think our medicine colleagues are really good at a lot of things, but I think of our team as the plumbing people. If these people come in with obstructive jaundice, even if it's from, intrahepatic cholangiocarcinoma that's unresectable, I think we do a good job at determining, do they need an ERCP? Do they need a PVD? Are we draining, all of the liver? Do they need multiple drains? And so I think it provides a good service for the patients. And at least at Duke, even if radiographically they have widespread metastatic disease, but without tissue, if they don't have an established medical oncologist, they aren't admitted to the medical oncology service. And so we often end up kind of owning these patients and helping to get them into the right space. And as far as resident versus APP, I don't know the best answer to that. Right now, our service, the residents get the consultations, but then of course, we participate in their care once they come to service. And I think a lot of us have a lot to offer with a lot of oncologic history. And I think the patients pick up on that. If you meet them, they can tell we've had over a decade of experience taking care of patients with that problem. And so I think that experience can be really helpful. So residents provide a great service, but I think a lot of them, they just want appropriate care, regardless of the title. So.
I'm actually interested in a lot of what you just said, because at Hopkins, where I worked previously, and at Northwell, especially patients that are coming in to the hospital jaundiced, like admitted through the ED. Oftentimes, I don't know if they're going on surgery services, but my experience, they go on medicine services. And back to kind of my point on my presentation of, you can only take care of the patients that you know about. Same goes for the inpatient side on the consults. So oftentimes I feel like that the GI doctors are, decompressing patients, and we don't actually know about them from the surgery service for quite some time. And to your point exactly, maybe you would take this patient right to the OR instead of stenting them. And then now you're having to wait. We wait typically like 3 weeks for, now when they've established biliary continuity before you're going to take the patient to the OR. So you run the risk of all the risk and no benefit of that. So how do you guys make sure that you're involved with the correct patients at the correct time to actually get the care done?
I think that general surgery is consulted a lot, for these patients who have, if there's any mass on imaging, for example, or any concern of malignancy, and then they do a good job of lateralizing that to our service. Also, I've been at Duke, 11 years, and a lot of the same people are there. So if the GI colleagues get a consult, then they may reach out to one of our surgeons or one of us and say, hey, this patient needs to be seen. Same thing with IR. I think a lot of the folks have just worked together for a long time. And so even if there's not an official referral, they will raise a question of, oh, maybe we should get our surgery colleague's opinion. And then they will, recommend the referral.
Going on the same topic, I think the next question is how to foster interdisciplinary collaboration among APPs in different departments and divisions.
I think a lot of that goes with continuity, like amongst our group. Many of our APPs in our group have been there for, we have really good retention, have been there for 10 plus years. And I think also the collaboration comes from the top, from our attendings. We have really good, our attendings have really good relationships with GI and IR. We do multidisciplinary tumor board rounds with them. And I think as the APPs on the team, have really good relationship with our GI and IR colleagues as well, and their APPs. So we're just, I think to our added benefit, just so comfortable navigating the system within each of our individual hospitals that that just fosters collaboration. And they do, just as like a side, they'll do like social mixers between us and IR, and just kind of to keep everybody there's new faces coming in so that everyone can kind of put a face to the name so that when we're calling an emergent consult at 7 o'clock at night because somebody's bleeding, they can, know who they're talking to. So.
Just to piggyback on that, one thing I would encourage for the younger members in the audience is just communicate and make yourself known. So instead of just placing the consult for, IR, place GJ, call them and communicate and just give them specific clinical information, because the more you can communicate with them and build that relationship, it'll just make the patient care more smooth. I think especially in the era of COVID, where we used to all sit in a room and have these multidisciplinary meetings, and that transition to Zoom, where, not everyone has their camera on. And so you're really just trying to recognize names if you haven't met them before. I think just that closed loop communication is beneficial. And then one other comment I saw in the question, there was referencing, kind of case management and whatnot. And until my inpatient experience, I did not appreciate the incredible amount of work that the case managers do. And Duke as an institution has made a big effort to try to decrease discharge barriers. And so a few of us a couple of years ago were kind of charged with helping to identify what can we do better, how can we get people out quicker with what they need. And it's really simple. But one thing that we found was very helpful is we now have a daily multidisciplinary meeting. And so every day it was 9 o'clock and now it's 10 o'clock. We meet with a charge nurse on the floor. We're working towards geographical location, but that's a whole other set of challenges. So we meet with our charge nurse on the floor, our APPs, my APP colleague Erica's in the audience here. And then the residents come when they're able to, our case managers. We recently included PT and OT. And it's been very helpful because what we didn't recognize is, we are really bad at estimating our estimated discharge date. Our patients change every day. So I may think this patient's going home in 48 hours. Well, then next morning they're throwing up and they get an NG tube and now we're, pushing back the clock. Or guess what? We thought that 85-year-old was going to do terrible, but they are flying and they're going to go home. But for whatever the reason, we're bad at kind of guessing when they're going to go. And these patients are complex and have a lot of needs. So if they have tube feeds and we look at the case manager and say, Mr. Jones needs to go home tomorrow with a GJ and tube feeds and a wound back. And they say, well, we need orders for the tube feeds and we need to set up home infusion and we need to educate the patient and their family. And then the patient says, oh, my daughter lives in Connecticut. They need to come up and get the education. So all that to say, we started these daily meetings to anticipate what do we think this patient's going to need. Our nutritionist joins us as well. And so we try to work together to put in the orders early so that case managers can put in their kind of referrals to the home infusion company and to skilled nursing facilities and get authorization and all of that. So that has been really helpful for us.
Now to go on to the next topic, like how to motivate the APPs to move towards more complex specialties. I would agree that one of the hardest jobs that the APPs are doing is taking care of HPP patients. They're much more simpler. I wouldn't say easier, but simpler patient population that you guys could be tackling. Means how do you incentivize new trainees to join APP?
This is obviously a very multifaceted question and everybody is different, but I think as a whole, and everyone in the room probably agrees, I think APPs are a very highly motivated group. And I think there's a lot of intrinsic motivation to work hard and take care of our patients and be a part of a team and be a part of something better. Tiffany gave many examples of the ways that APPs can benefit the program, the health system. And so I think a lot of this really is sort of a call to action to the surgeons that we work with, the senior APPs on a service, that when you're bringing on a new APP to really have a conversation with them and understand what they're interested in, what their goals are, how they might like their career or professional development to evolve over time, so that you can sort of look at the opportunities and needs that exist within your program or patient care, whatever aspect that it is, maybe it's academic work, and try to align that with the workforce that you have. Because I have at least found on my team, when you can provide opportunities to people that are work that they want to do, whether that's clinical scope of practice work, like being very autonomous in clinic or being involved in QI projects, that there's a lot of just intrinsic motivation to continue to keep working in those complex specialties. And sometimes that's, over and above the 40 hours that we all get paid for. But if you can align that as much as possible, I think it really helps retention, which ultimately is sort of what we're all going for.
Just chime in quickly on that. And then when you when you are doing something that is something that you're passionate about, that, your surgeons have said, yes, let's dedicate some time to this. It makes the off work time and investment into it a little more palpable, I should say. When easier to swallow when you're doing something on your off time that you actually enjoy and you feel passionate about. So I agree. Finding that kind of balance is important though.
And I was just sort of saying the same thing that you guys said, which is just to sort of foster this environment that people want to work in. We're a group of 7 people. We all support each other. We all encourage each other. We try to be flexible with our scheduling, and we really are each other's cheerleaders. And we work within our APP group. We all really get along. And then we work with a really great group of surgeons that support us, and I think we feel very supported by them. So I think at the end of the day, you just want to work in a place where you feel valued and where you feel supported by your colleagues. So
Just one last comment on that. I encourage everyone to be a mentor, be a sponsor, because that's how you're going to get people interested in your subspecialty. So I joined our group. I was dreading my surgical rotation as a PA student. And then I met Dr. Blazer, who all of our Duke folks know. And then when he needed a PA, I left my job in medical oncology to join him in Duke. And so he's still my, supervising physician all these years later. So get involved. If you have a local PA program, they're always looking for preceptors. So we take first-year PA students, we take second-year PA students, and many of them probably don't know what the HPV world is. And so if you can give them a positive experience, you may inspire them to then maybe they want their elective rotation in HPV or to consider that in a future job.
And so the next question is similar, but instead of clinical motivation, scholarly motivation, right? Means how do we incentivize APPs to do scholarly activities? Should it be required, mandated, a financial incentive or something else?
I think my answer to this would be somewhat similar to the answer I gave to the first one. And I think financial incentive is great, and that, it's sort of the thing that comes to mind first maybe, but I think there's a lot of other things that APPs value, particularly just even the experience to be involved. And so again, I was really fortunate when I started at 23 years old and no experience in HPV at all, that I had a surgeon who said to me, what are you interested in? And gave me the same opportunities that he gave his resident and junior faculty, and said, if you're interested in this and you want to do the work and you put the time in, you can go to meetings and present and be involved and write papers and do all of these things. So I think for me, it really was just somebody showing some investment in me and sort of affirming and validating that just because I was an APP, I was still eligible and still could participate and be a really important part of this area of medicine. And, like Megan said, at the end of the day, we all just really want to feel valued, and we want to feel valued in the specific area that we're interested in. And so, again, to senior APPs, or if you have a good relationship with the surgeons that you work with, don't be afraid to speak up and sort of ask for the opportunity, or just say, I'd like to have a conversation about getting involved in research and things like that.
And if your physician is not doing that, ask them or find a different one.
Yeah, hopefully you have enough data to sort of determine whether or not you can ask the question or if it's time to start looking for another one. But yeah, I think that, I don't think that if you haven't had that conversation with your surgeon, or your surgeon or physician hasn't had that conversation with you, for the most part, it's probably not a conscious thing. I don't think that all physicians or surgeons maybe recognize that we want to be, or some of us want to be included in that way. So, take them for a cup of coffee, or while you're running behind them in the hallway or between rooms or whatever it is, just say, hey, I would be interested in XYZ, or present a problem or an opportunity that you've noticed. And a lot of times it does come with some extra work that then you have to do, on Saturday night or something like
always
that.
comes with extra
Yeah,
work.
it's always extra work. But again, I think to speak to motivation, if it's what you're interested in, if it advances patient care, or it can make Tiffany and I, when we were at Hopkins, we worked on a lot of initiatives together that we did on nights and weekends. But the goal was to make it easier to take care of our patients and to get through the day. And we loved doing it. And we liked working with each other. And so it doesn't seem like work. And I think that's the goal. If you can create that space for yourself, then you enjoy doing it.
And it's putting in the time and energy now to hopefully pay off dividends in the long run, right? Like at Hopkins, I did patient education sessions, right? It took a lot to get them up and running, and it was weekly sessions where patients and their caregivers would come, and it was like an hour and 15-minute class that I was giving on preoperative expectations for patients undergoing a Whipple. While time consuming, but the dividend paid off in the fact that we weren't getting all of these patient phone calls in the office, throughout the day or throughout the week. So it actually helped a lot of my colleagues as well, because it was open to like all of the patients at Hopkins. So it's putting in the time and work now, but you're going to get the dividend in the back end.
I'll just bring up recently, we started like in the last 3 or 4 months, MSK started doing a clinical ladder program for our APPs. They do it for our nursing staff. And so this is recent. You get incentivized. So all of these education projects that we're doing, presentations, papers, abstracts, you get points for. And then based off a point system, you are promoted to based off the clinical ladder to a 3 or a 4, and then incentivized monetarily based off of that. So it's just a way to kind of take all of your accomplishments and get paid for them a little bit extra. But I realize that comes from an administrative standpoint, and I'm not even fully aware of all of the hoops that had to get, people had to go through to get that up and running. But it's just something that I think is sort of novel and new. I'm not sure if anyone else has that at their institution, doing a clinical ladder for APPs. Yeah. I mean, they do it for our nurses, but yeah. Yeah. For that, yeah. Totally agree. But it's just a way for you to take this presentation that you did and get recognition for it.
It's nice to see the institutions and the health system support that. And I do think that there's becoming more and more widespread sort of acceptance or recognition that things like that are needed, because APPs are doing a lot of really valuable work. And so for the institution to support it and to give you a little bit of money for your effort,
Yeah.
it makes you feel good.
I think coming from a different place too, we look for support from our colleagues, we look for the recognition from our surgeons, and then this is just coming from a different place from your institution.
I'm going to use that as a plug to encourage all of you to get involved, because I think this is a really great APP community, and there are so many ways to get involved with upcoming webinars or the conference next year. It's a great way to these points of showing your institution all the good work and sharing your expertise that you all have. So please get involved with us, because I was a team lead in my last role as well. And I would tell my team members, brag about all this great stuff you're doing. Because if I'm trying to look and see who can we justify for exceed expectations, you got to show me, document this. I know we always feel a little bit awkward, maybe we're bragging, but no, you do all this work, put it down on paper so that there can be some benefit. And again, we're always looking for people to get involved.
And there was a Instagram or a TikTok video that I saw yesterday. So don't keep just working hard, work hard and brag. Otherwise, nothing's going to happen. You'll never get a raise. You'll never get a promotion. So I'll go to a clinical topic. Somebody asked about Do you guys do hepatic artery infusion pump? What does it take? How can we get the APPs ready to go? Should we be scared?
We do a lot of hepatic artery infusion pumps at Sloan. I think our main role, which Sarah will sort of confirm this as well, is we do a lot of communication with well, as everybody probably knows, it's multidisciplinary. There's med-onc, you need GI, IR, everyone's got to be sort of comfortable with them, and willing to manage them. We do a lot of communication with our medical oncologists, filling the pumps, communicating with them if there's any infectious concerns, sort of communicating the surgery. If they've had liver resection or any ablations, they'll hold off on putting chemotherapy into the pump longer. Rather than if it's like pump only, they'll put chemo in it a little bit earlier. So we try and be that communication piece with the medical oncology team and their APPs. We facilitate the nuclear medicine pump study, and kind of communicating with our chemotherapy team about filling the pumps before they leave the hospital, and do patient education with the patients about, activity restrictions. The Intera pumps, you can't put hot packs over. So we had a patient who it was sore over their pump site, so they put a bunch of hot packs over it, and then they emptied, dried out the pump. And just making sure that the pump gets filled before they leave the hospital. And then, I think we've been in talks next year to try and give like a bigger presentation on all this, but managing all the complications that come with it, like patients who develop HIT, we fill the pumps with heparin. So kind of just figuring out how to they have to now be filled with fondaparinux or pump catheter infections, or the sequelae of pump chemotherapy, they can develop biliary cirrhosis. So it's just kind of like managing all of those different complications or things that can come up. But it's like a really rewarding, I think, surgery, and the patients are really grateful to have them and sort of willing to do whatever they have to do. But I think that's like, in a small paragraph nutshell, our role.
And I think we had a slightly different experience because, Memorial's been doing that for a long time. And then a few of our surgeons came from Memorial and started the pump program. And so it was really nice because they integrated the APPs from the start of it. So we were using, the Medtronic pump initially. And so we were meeting with the reps, and I do not operate, I leave that to Anna, but I went into the OR to at least see them place these pumps to have a better understanding. And then, my main role on the floor is protect the pump. I gave Litsky an ornament one year for Christmas. It said protect the pump. So it's really just a continuity, especially it was new to Duke. And so my job was to, make sure, monitor for any signs of infection, educating the residents, educating the patients, and then really helping to coordinate that multidisciplinary appointment. So I would typically access the pumps for the nuclear medicine study, or sometimes post-op, but there's just too much swelling, especially with the Medtronic, the Intera, much easier. It was just hard to access. And so if IR did it, I would go down for those studies because it would really get put in whatever IR room is available. And those residents or fellows may not have been familiar. So I would make sure they had the right sequence of events and flushing with the hep saline at the end. And once we had two different pumps, sometimes patients would come in with pump complications and they would page me to go down so I could make sure that they're using the right needle and the right sequence of events and to help troubleshoot that. So I think it was just really important to coordinate with medical oncology, nuclear medicine, interventional radiology, the outpatient pharmacist, because again, don't let the pump go dry. Those are the two rules. I protect the pump, don't let the pump go dry. And so just making sure they would just look to us because the residents have a million things going on, like, oh, Sarah and Erica will take care of it, make sure they leave with everything that they have. Then we do this outpatient communication, looping in our outpatient colleagues. And now Anna helps to place them intraoperatively for the robotic pumps.
So we'll go for one more question. This is about finances and billing. So what's the benefit having an APP in the OR? And is it worth having an APP take care of post-op patients when you can't bill for them?
So I guess from the OR standpoint, I don't know what other models do at other hospitals and institutions, but we kind of developed one for me a couple of years ago. where the goal would be for my yearly RVUs would essentially like pay my salary. That was our big goal and big initiative. So from a financial standpoint, we exceeded it tremendously, I guess, just with volume from surgeons. But I think it's from a good standpoint, billing wise, and also from a learning standpoint, because the residents, we have 2 consoles, so the residents are able to get on the console and be able to operate and kind of help refine their skills. In addition to having a surgeon there as well, and they can't bill for a first assist. We can, and that also saves from having another dual attending in the OR, because 2 attendings a case for robotics, no attending wants to first assist, no attending wants to bedside. So from a financial standpoint, it really is I think it's very beneficial, and from a training standpoint as well.
I actually asked the second question, and I'm happy to open it up to the group if anyone, this is just something that I think we've been ruminating on in our group. It's come up a few times, is how do we monetarily prove our value inpatient? Because we're not billing for all of our time that we're spending with patients, that we are managing their drains, that we're calling IR, that we're wheeling them down to CAT scan, that we're calling their primary care doctors, that we're dealing with family members. How do you show the value in that? Because everything's gotten so geared towards billing, and how much money you can generate, that and for us on hepatobiliary at Sloan, we're looked at sort of side by side with our colorectal colleagues. They will have like 15 patients each, and we will take 7 to 8 each. And so the institution wants to know, why can they take 15 patients and you guys can take 7 to 8? So they look at us side by side and want to know, why is there this difference? And so it's really hard to kind of how do you explain what you do on a day-to-day basis and explain why it matters? That's what I think is just difficult to explain on like a billing perspective. So it's a question that we ask ourselves all the time, and I think try to come up with. I've gotten a few ideas this week, just talking to some of our old fellows who have gone on to start their own programs. Just how can we prove that we know our value and our attendings know our value, but how do we prove it on like a billing money on paper?
That would be the non-clinical administrators looking at this situation, right? Because they don't know, period. That's my easy answer. So clearly the HPV patient populations are way more complex than any of the other populations that we see in the hospital, right? These are gigantic operations. They require a tremendous amount of coordination of care. They have high post-op complication rates. So you cannot really compare apples to apples there. And I think maybe even having one of your surgeons or somebody in the higher clinical, one of those clinical leadership roles, try to explain this to the non-clinical administrators that are judging on solely by numbers, may be helpful, because the impact of the time spent in care of these patients versus the time spent in other disease sites, you can't really compare them. But in terms of creating additional opportunities inpatient for reimbursement stuff, like we did a lot of enhanced recovery pathways that are on the inpatient side, and clinical guidelines on the inpatient side, so that we're getting patients, out of the hospitals sooner. Kind of creating that kind of stuff can also be helpful. We had somebody back there, yeah.
Right. That's great. Were you able to show a significant difference? Yeah, length of stay seems to be the common. Okay. Okay, that's, yeah.
The other thing, Megan, they talk about it's in the global period, but there is a percentage of the global payment that is allocated and it's postoperative care, right? So if you really want to get into the math, you can sort of figure out, X percentage of the total payment is being attributed to this care, which you guys are providing, right? And so, I mean, there is some payment for those services. Quantifying the non-billable value really is what you're trying to do. And so
Yeah,
we
it's
have
just like, I feel like not I think our surgeons understand. I think like our direct
administrators don't,
managers,
yeah.
And they're like, what do you do all day long? And I just want to be like,
Come
well, let
along
me
and
just
spend the
put
day with
a
me.
birdie on my shoulder and you can just follow me around and see
Yeah.
what we do all day.
But, we've had a little bit of success looking into the non-billable value. There is some, information in the literature and papers out there about that, especially in oncology. So there is some precedent out there. We did start including advanced practice sort of in the language of questionnaires that go out. And so there are, HCAPs and CGCAPs and trying to pull your comments, patient comments, that when we did that, we saw a lot of them. Allison's an inpatient APP and there's all these nice things written about her, but sort of a black box. Nobody knows that. And so starting to collect those comments and really look through them was meaningful too.
I don't work inpatient now, but I did see a question here about the post-op piece and you kind of touched on as well. Well, part of the global period, it's offloading from the physician schedule and really time is money on their schedule too. So, right, say you take all of these post-op patients off of their schedule and they are saving now this much time, not seeing those patients. And what could they be doing more with the time that you are offloading from their schedule? And it's been a lot more of a focus on the physician billing and the physician time spent. So if you are saving the physician, say, I don't know, 5 hours, right, of their time. And then I would say, well, okay, you could actually do a Whipple in 5 hours and you can take, and the average, cost of that is like $52,000 for us in the state of New York. So you're saving that time that physician can now be doing other things as opposed to seeing the post-op patient. So you can also go that direction too, in terms of what you're offloading off their schedules to what they can be doing and making money for the institution. So it's not, for not, we provide a lot of value from that perspective.
And to piggyback on that exact same thing, even if they don't go and do a case, if you guys are in clinic and do the exact same thing, it's still cheaper for the institution for you to do that work, not the surgeon, right? The profit contribution margin clearly comes, we know the surgeons make much more money than we do, right? So there's a lot of different sort of angles that you can take. It is harder in the inpatient realm, but again, just sort of, think through these concepts and how you can try to make an argument that's going to resonate at an administrative level. Yeah.
I totally agree. The quality of control, that question that I asked before, with APPs who have been on the surface of 5 to 10 years is much better than a resident who's going to be there on the service for a month or so. Might not be even interested in HPB.
And that may
Um,
be interesting to look at readmission rates of patients discharged by, residents and fellows as compared to ACP. That could be another good thing to look at it and make a point. What'd you find?
Yeah, one of
course.
our,
No, I meant-
one of our previous
course.
fellows today just actually said to me, you guys are reevaluating the patients 3, 4 times a day. You would discharge a patient today that could go home that we wouldn't see till the next day and maybe keep them an extra day. So he's like, I think you need to focus on length of stay and how you guys drive the length of stay down significantly.
So we need to take a quick break. One last question.
Well, they're saving money on the readmissions because they're coming back in.
When they
So I was going to answer Megan first, and then we go on a break. To let your manager know how much work you're doing, don't come to work for a week. They'll realize that. Okay. A lot of stuff that we do on HPB is coordinations, and they don't even like MIS robotic. They don't have CPT codes, therefore it's not billable. But we are doing it for the patient, so that's why we do it. One way to, again, hard work and brag is to measure everything. One thing that we do, if you guys have Spectra phones or things, the number of phone calls from the nurse to an HPB nurse coordinator is much. Is going to be much more than the phone call that the colorectal people are getting. Okay, so there are ways to measure it. They might not be just billable. We are going a little overboard time. The next session is at 3:45. So if everybody can take a 10 minutes break and reconvene. And we have a wonderful talk from Sabrina from Stanford.
You guys think?
Okay. So it's 3:45, so we should get ready for our last talk. If everybody could sit down. So I'm going to introduce Sabrina Aziz. Hello. Hello. So I'm going to introduce our last speaker, Sabrina. She's with Stanford University, and Dr. Visser is here. So Sabrina, for our last talk. Thank you.
You have to stand over here. Hi, my name is Sabrina Aziz. I'm a PA. Presenting today alongside Dr. Brendan Visser. We are from Stanford. We feel very passionate about this topic because we're providing great care for our patients and have grown a lot over the past 3 years since I joined Stanford. There are studies that show that experienced bedside assist will are associated with decreased length of stay, lower EBL, lower positive margin rates, and lower operative time. So when we talk about robotic surgery and bedside assisting, like what does that actually look like intra-op? This is like a short clip of that. Not only do I'm an expert in how the robot works, but I also utilize a lot of my laparoscopic skills. So we're just manipulating the liver retractor, introducing the ultrasound probe, looking for a lesion, do specimen extractions. I help manage intraoperative bleeding. It's a very controlled situation here where, due to how we position our patients, I wanted to just highlight that I was able to suction and change instruments at the same time. For intraoperative bleeding, I also do a lot of stapling for this patient in particular, her anatomy. There was a lot of stapling from the bedside. And again, where we put our support allows me the ability and the flexibility to staple in all different parts of the operative field. So what makes me an expert bedside assist? It's just a little bit about me. I started working, my first job at a PA school was at Mount Sinai Hospital. I covered a surgical oncology HPV service at night. And I did that for a couple years, but then I got a little bored and I wanted to do things like more hands-on. So I started working at Lower Manhattan Hospital in Manhattan. And this was a surgical PA service, and we were affiliated with Cornell. So we would go up to Cornell, we would train in laparoscopic skills and also open first assist. We would also train in sorry. I wasn't nervous at all before, but now I was super nervous. But so we basically would train at this job as a surgical PA.
we first assisted in lab and open surgery, and we were affiliated with Cornell, so we would go up there and we would train in their lab. And at Cornell, this is where I met a surgeon. His name is Ben Golis, and he asked me if I wanted to join him at Mount Sinai. So when I started there with him, he was starting his journey in robotic surgery, and this was a very unique experience for both of us, and especially for an APP, that I was able to train with him. So I did all of the dry and wet labs with him, and we would go to case observations together, and we really built up his outpatient practice and provided great care for our patients. And from there, I joined Stanford in 2020. And just a little bit about Stanford's robotic APP program. It was a little late to start. I know a lot of people have been doing this for a while, especially MSK has had robotic APP for a long time. So they started their robotic APP program technically in 2019, and it was only consisted of one APP, and she did urology, and she had been there for 15 years. And they had 4 robots at the time, and they were distributed over 2 different hospitals. And then when I joined, the role was to just be an operative PA. So we spent all day in the OR, it's 410s, and we just did robotic cases. Now in 2023, we have 4 robotic APPs. Now we have 6 robots, including an SP, and we got rid of our FI. These systems are located over these 3 different hospitals. Huge campus. And just quickly for people who don't know, what is robotic assisted surgery? It's a minimally invasive procedure performed through very small incisions. We specifically use the Da Vinci Xi, which is composed of 3 different components: the surgeon's console, the vision cart, and the patient cart. This is one of our older rooms, but this is how we typically do our setup, where we have 2 consoles, where there's an attending surgeon and the fellow or a resident, and I'm there at the bedside. And why robotic assisted surgery? It allows the surgeons to perform complex procedures. Like these consoles allow them to see in 3D. We have wristed robotic instrument arms, and we have this feature on the vision card, which is called TAL Pro, that allows us to see the operative field and things like the EGD images or ultrasound images at the same time. So I'm just going to talk a little bit about how we were able to grow what I've done over the past 3 years to and how we've grown the robotic program at Stanford. I was able to separate these next few slides into 3 different parts: pre-game, teamwork, and consistency. So part of my pre-game when I started at Stanford was observing all the things, like the workflow, the strengths and weaknesses of the OR, and taking like lots of notes. And I would put them in my phone. So like every day before a case, I'm reviewing my notes for each specific surgeon. And remember when I said we have 3 different hospitals, so every hospital OR is set up a little bit differently. So I would write these little notes in there about how the room should be set up. How is he starting his case? What instruments are going in what arm? And also back to the strengths and weaknesses of the hospital. One of the things that I noticed was that if we needed something robotically or something got contaminated or was missing, you could potentially have to go to another hospital to get it, and it could take a long time. So this is part of me reviewing my notes and making sure that we had everything in the room, and learning how, as an APP, how I can incorporate into my team, incorporate myself into the team to just elevate the whole robotic experience. And before cases, if I didn't know the particular case, I would either ask my fellow PA, or I would Google. I would look at YouTube, and if Google and YouTube didn't have any resources, I'd reach out to my intuitive reps. This is just an example of a procedure card that they would give out, and it just details where the ports are going to go and how to position your patient. And then, of course, we all know, like, make sure that you know your patient before going into the OR. Teamwork. So I took all that information, analyzed it, as I said before, like, how can I incorporate myself into the team? And one thing I learned is that it's such an important step when I walk into the OR to like assess who's there for the day. So you're not always going to have like our star fellow or our favorite scrub, or, you know, it could be like a questionable traveler. So, yeah, this is important because then you communicate with them and see like where, you know, I answer any questions that they have and kind of get the room going. And then I assess the room. Is the surgeon's console in the right spot, or is the surgeon console even in the room? Sometimes things are missing, trust me. And, you know, is the vision cart in the right spot with the ultrasound, and is the patient cart in the right place in the room? And if something is not in the room or needs to be moved, I've learned how to move things. I'm a small person, but I can move that patient cart. Equipment, I make sure that we have all of our instruments and all the equipment is set up appropriately. Like this is the vision tower. It has a lot of settings on it. So I make sure that I check that before the case starts. Make sure the Talpro is set up. Make sure all these I have learned how to configure all these wires in the back at this point, because we have a whole, usually if something goes wrong in a case, and if I'm not there or Dr. Brisser's not there, well, not, he's always there. I'm just saying, like, if someone like me is not there, or the biomed team, we call them our biomed team, we would have to call this team of people to come in, and they would fix the wires in the back. But it would just delay the case. So I just learned how to do it myself. So if a wire's not connected properly, like I know how to fix it. There are no delays. And then I help in any way that I can. If the robot needs to be draped, I do that. If anesthesia needs an IV, I help with that. Like I'm doing all the things in the room just to get things moving for the day. And, you know, the one complaint from the staff is like, oh, there's so much stuff. So whatever I can do to help them, help the team, I try to do that. And then pretty self-explanatory stuff, like, you know, the more you do it, the better you get. You build trust between the surgeon and the team, and you become more efficient. So I'm going to do a quick case review. This woman, she's a 76-year-old female. She presented with abdominal pain and back pain. She was found to have an elevated lipase. They did a CT abdomen pelvis that showed dilated ducts, and EGD EUS findings positive for IPMN. She had a significant family history of the plan for her with the robotic pistol pain. Review of the imaging. This is a classic like double duct signs where the bile duct, pancreatic duct are dilated, and her IPMN is located in the body of the pancreas. And this is important because, I wanted to show you back to the Talpro. So this is, I know you had seen a quick clip of it earlier, but this is what this looks like intra-op. So on the top of the Talpro screen, you can see that's the dilated pancreatic duct, and below that is the splenic vein. So now that we know that the lesion is a body lesion, not a tail or a head of pancreas lesion, this is how we determine our positioning for the case. So we typically do lithotomy for these patients. I know a lot of you are probably thinking like, why are they doing lithotomy? But there's two main reasons why we do this. One is ergonomics. Like this allows me to sit in between the legs of the patient, and I can use both of my arms. Like for someone like me or someone who's in the OR every day, if you're using a lateral port and you're using your arm throughout the entire case, like I've gotten injured in the past during a 10-hour case, I got tendonitis in my shoulder. So this allows me to be like really ergonomic and allows me to have access to the entire operative field. So this is how we usually place our ports. They're off midline. The cyst port is midline and lower on the abdomen, and we separate them about 7 centimeters apart. These are what the instruments we usually start with. Our fenestrated bipolars, and then is in arm 1, a camera in arm 2, and a scissor. And then in arm 3, this is our exchange arm. So we exchange multiple instruments through this arm, and we use another valve retractor in arm 4. Starting the case. So every time I see this picture, it makes me laugh because I know that they're all staring at me because I'm obsessing over the cord. There are so many cords and things that are there's just so many things with the robot, and I obsess over them. So I know right here I'm fixing the cords, and then I do another thing called like lights, camera, action. So at Stanford we have 1 million lights, and so I make sure that all the lights are out of the way, all the screens are moved out of the way so that we can dock the robot. This is just a short video of us docking the robot here and make sure the camera's ready and it's cleaned. And I'm telling the nurse to bring in the robot at the exact time. So that was our attending Dr. Jewett. This is not the distal pain case. This is actually a different case that I have a video of, but this is for a choledochal cyst resection. So docking the robot, when you see somebody do it, you're like, oh, that looks easy, I can do it. But trust me when I tell you, it can be very difficult, and you have to make this move along at an efficient speed. It's good to have experience with it and know how to separate the arms appropriately, load the instruments. Like, this is sped up, but in my head when I'm doing this is how fast I'm moving, but I really not. So interop. So now we did all of our pre-gaming. So now I'm just following the lead of the surgeon, anticipating his next move. I also do this thing where I speak loud and clear. So in an ideal situation, like, everybody in the room is paying attention, but that's not always the case. So if I know that he's going to need to staple or stitch something, I'm saying, are you going to stitch that? Are you going to staple that? So that prompts like the nurse and tech to have things ready on the back table. Like I said, if they don't have something, it could take 30 minutes or 20 minutes to get it. And then another thing that improves efficiency intra-op is doing that arm exchange through one arm. So he doesn't have to say, can you please take out this instrument in arm 3? I already know that I'm just exchanging instruments through arm 3. Sometimes he doesn't have to say anything at all. He does this move where he just always moves the instrument up, 12 o'clock on the screen, and I know him well enough now that he's ready for the next step. And then closing, I just make sure everything's ready for specimen interaction, and we have all of our closing supplies. There's times where we undock the robot, I take out the specimen, he's scrubbing, or the fellow's scrubbing, and they walk into the room. They're like, where's the specimen? I'm like, it's already out, like on the back table. And they're like, oh, wow, but these are things that save time and improve efficiency and OR time. And post-operatively, this woman did fantastic. I didn't know when I picked this case to present that she had said this post-op, and this makes me feel amazing. She was surprised that she felt so well. She was asking the PA, Kristen's not here, but you guys even do the surgery on me? She had no pain, and she didn't have to take any pain meds. That's amazing. This is, oh, sorry. So about our growth. So patients are doing great. I started on the team in 2020. So this is a number specifically for Dr. Visser. So he was kind of, the term you like to use, like posting along before I started from 2016 to 2020. That was like COVID year. So things were kind of weird then. But we have like more than doubled his numbers since I started. And this is all about just improving the whole OR experience. And moving things along more efficiently that have built trust, a good relationship. And in conclusion, a robotic APP can be like the center or the term that you use, and I don't remember it now. We are the core of this well-oiled machine of robotic surgery and the whole experience. So, just take all of these. I just remember to do all these things in the morning, my pre-gaming, like I go through my chart, I go through my notes, that's the team, do all the things with the team in the morning. The OR runs very smoothly. And we are essential to the team. And we've seen overall our robotic numbers at Stanford since we started the robotic ADC program have increased significantly. I think for general surgery, I don't have those numbers here, but I think it was like more than 100%. Thank you.
Make a brief comment. So I don't have to tell the APPs that this is the classic role where my name is somehow on the slide, the first slide. She does all the work, and somehow I share in any of the credit. So that's the role, right? I really am super appreciative. I mean, I think she brings an intentionality to this job. It means that there's efficiency added to the process to allow us to say, okay, let's do more cases robotically. So like those numbers are not gallbladders or hernias. We're not doing what, but it does mean that cases that I once upon a time would do open because I'd have variable bedside assistance. Now I say, oh, gosh, that's a very complex case, but because we have a really consistent, talented, super intentional bedside assistant, we'll give it a go and we can do it safely and extend the benefits of the minimally invasive approach to more patients. And so it isn't necessarily like my practice. I am a super busy surgeon. I operate the same number of days a week all that time, but there's a group of patients that we now offer a robotic approach that we would have done open in the past. And I think that's what, that Sabrina brings. And honestly, any of those of you who are interested and can do it in the same kind of intentional, really thoughtful way that Sabrina does and bring her A game to work every day, could build a program for your partners as well. Yeah, interestingly, so we haven't looked at that very specific issue, and I think that's a great idea and an area to look into, see how we can quantify. And I came in at the end of the first portion of this APP session. Wearing another hat, I work really closely with our inpatient and outpatient APPs, and we have a super robust team in HPV surgery in that clinical space as well. And we struggle with them, that measurement of how the amazing impact that they have on that side. And I think figuring out how to quantify in the operating room is also really a great idea. We actually have looked at and are looking at and near publishing, they're presenting, Aspari presenting sometime soon, looking at robotic versus even lap distal pancreatectomies to look at this cost issue. Because we have transitioned to the great majority of distal pancreatectomies. The robot adds a little bit of expense. The robot patients have a lower conversion rate and a shorter length of stay. When you look at cost, it's so tricky because the hospital accounting, it's attributable cost, right? So we actually pay something for a robot instrument, but we also, in the economics of cost, you attribute OR minute cost, and they attribute a much higher rate of cost to every OR minute in a Stanford's accounting than they do a laparoscopic minute because of the infrastructure, because of the paying for the robot and having to deduct that value over the number of years that they decide a robot has its lifespan. But so we have not yet been able to demonstrate, but it actually is really very small difference because of those other elements of like, I won't tell you how much, but it's expensive to stay one night at Stanford. And your timing is good because I'm actually meeting with Entwistle, our CEO, this week, talk about ways to sort of and pathways for patients like minimally invasive distal pancs to get them out of the hospital even sooner than our current 48 hours. Like everybody goes home at 48 hours, shorten that further.
So on that pre-op imaging that you showed with the double duck sign, I imagine was maybe more of a head mass, or I'm not sure.
Oh, yeah.
Well, so my question was going to be more of, are you doing, robotic Whipples now? And if not, what does that look like in terms of training like APPs and advancing, to more complex surgeries with the robot?
Yeah, so we do robotic Whipples. So that my practice has always been very selective for robotic Whipples because I think the juice to squeeze ratio is not giant, and so and I'm not super passionate about sort of trying to do every difficult Whipple robotically with only the expectation I'm going to convert a big chunk of them. So I really actually do robotic Whipples that I have a confidence that our conversion rates can be 5% or less. And because I didn't have this reliable bedside assistant, I actually used to do Whipples hybrid, which is I did a laparoscopic resection and a robotic reconstruction because then I was at the bedside. because, I have a terrific fellow, and half of the year I have the fellow. Some of the times he's actually operating with Dr. Dua, my close partner and friend. And so I didn't want to be dissecting on the SMV and across the room unscrubbed when I didn't have a reliable partner at the bedside. So now, if I look at the next month, we have 3 Whipples that Sabrina and I are doing together. So like that even has evolved because of that partnership that a really, really strong EPP brings.
And I forgot to add earlier that education is a big part. We have residents, and me being there allows the fellow or the resident to be at that dual console. And if the fellow's at the console, I'm offering the resident, a junior resident, a unique experience to like learn from somebody who is an expert at using the robot. That's something they didn't previously get.
Because my raising my voice from the corner of the room is not apparently enough education. They don't
The
get
more
better
he
instrument
talks, the
changes
more
or get
unhappy
faster.
he
I
is.
don't know why. I have my head buried. I just speak louder.
So Dr. Wizard, would you reschedule your OR if Sabrina was off for the day?
So that's a good question. We struggle because I don't get Sabrina every day, and she actually covers other specialties, and the other specialties, like she works with the thoracic team, they equally have sharp elbows because she is in demand. We do change, honestly, it changes the balance exactly of how we do it to the detriment of the trainees. There's all these sort of downstream to the detriment of our efficiency in the day. So we don't, I also have patients who have a tumor and I schedule way out. And so I can't be like, but we have tried to do a better job and with it, because there's a larger APP team, at having a better prospective look at the schedule, figure out where is going to be competition for her skill set, and try to plan around that. But I was just mourning, we have like Dua's doing a cold oak assist and I'm doing a robot whip on the same day, and we're trying to figure out how to, and honestly thought, gosh, we got to do a better job scheduling so we don't have that, because now, it's well.
I just wanted to add to that, like the short answer is no, they technically don't. You don't switch your schedule around if I'm not going to be there. It's just more painful for you. And like things happen, and I was going to talk about this, but I forgot. But there was a situation where the nurse didn't pair. We used the trunk bed, which you can pair with the robot. And the nurse said at the beginning of the case, I paired the robot, but it wasn't paired. And in the middle of the case, they were struggling with the operation, and they called DV Stat, and they told them they had to shut down the entire system and start over, right? And then
Just like that can't happen. But we also, Sabrina does actually help get the room started with the setup and those other instrument setup, nursing staff pieces, even when she can't be there physically, and then switches around a lot of times.
yeah, I take a lot of time, make sure I take a lot of time in. This is part of like assessing the team. It's like, what can I teach you and what can I show you, so that even when I'm not there, that it's not a painful experience. It's all about growth.
Very good.
So we've never had, well, I think only once with you, we've had to convert to open, but it depends on the staffing. Like if we're converting to open and they need help, I'm going to help them because I'm scheduled to be in that room anyway. If they have enough residents and they have a fellow and they don't really need me, then I leave, and I either, I help my team out and see if there's any other robotic cases that are not being covered, or if my teammate needs a break, I will give them a break. But it just depends on the staffing. And I ask the surgeon, like, do you need me? Do you want me to stay? Sometimes they say yes, and sometimes they say no.
Yeah, like just to echo her point, honestly, we don't really convert almost. And honestly, it's because in part, we have a dynamic, a team, we like a lot of conversions are in part about bad case selection, but then technical mishaps or exchange things, or inability to rescue quickly enough because we're not getting those instrumented changes fast enough. So like when you have that really very well-oiled machine that I think that she's been able to bring to us, I think it really honestly reduces that risk very significantly.
We'll take one final question.
The latter, yeah. So like she pointed out, the pancreas, based on where that lesion is, you move that in a more distal spot, then we touch base early in the morning because she's already looked at the scans and she'll say, do you want this one lateral? Because if it's quite distal in the tail, then we'll rotate the position, change the port positions, and but she knows different versions and has studied the scan. The stand, yeah, it's low midline also, camera just to the right of midline gives her access right up. I use the robotic stapler for some operations, but like because she's the bedside and her stapling is so precise and it gives really good repetition and safety. And then for like divine pancreas, so I still use, in fact, the bedside stapler for the great majority of cases that we do.
Thank you, everybody. And congrats to all the speakers. Wonderful job. You guys next year. Wonderful. Yeah. Have a good.